The recording. Great. So today's session, titled Harnessing Member-Centric Strategies to Support Members with Complex Conditions, is brought to you by Scene Health. Scene Health is an MHPA Silver Partner and a longtime supporter of the association and our member health plans. And I just want to thank them for convening today's distinguished panel. With that, I'll go ahead and turn things over to our moderator for today, Jamie Schneider.
Thanks so much, Eric, and thank you for joining us today to talk about how you really can use member-centric strategies to support members with more complex conditions. Just in the way of background, I'm joined today by 4 industry experts who will be able to provide insight on how to really use member-centric strategies to drive meaningful health outcomes, to proactively mitigate high-cost incidents, and to cultivate personalized engagement for your members. According to the Center for Disease Control and Prevention, 6 in 10 adults in the United States live with at least one chronic condition, and 4 in 10 live with 2 or more chronic conditions that have been linked to higher mortality rates, functional decline, and reduced quality of life. The care of chronic conditions has historically been fragmented and costly, as we all know, oftentimes consuming as much as 80% of state Medicaid program budgets. And as a former Medicaid director, I can tell you that's something we really want to look closely at if, in fact, the spend is really at that level when it comes to serving members with more complex needs. So prioritizing member-centric approaches can elevate not only the quality of care for members, but can also result in improved HEDIS performance scores and narrowing care gaps. And that's what we're here today to talk about. So I'm just going to start by introducing you to the various members of the panel for today's discussion and allowing them the opportunity to talk a little bit about their background coming into the conversation. I'll start with you, Carrie Ann.
Thanks, Jamie. Hi, everyone. Nice to be with you today. I am Carrie Ann Johnston-Guth. I am a social worker by training, and I work for United Healthcare. I am the director of our chronic conditions clinical strategy within our community and state line of business. I've been with United since 2018 and have worked in a variety of complex care programs, initiatives, and strategies to improve the outcomes for our members with complex health and social needs. Prior to coming to United, I grew up in healthcare administration at a hospital in Camden, New Jersey, Cooper University Healthcare, where I held a variety of management and leadership roles, designing, developing, implementing, and operating population health programs, including serving as a co-founder of the Division of Addiction Medicine and leading our Department of Psychiatry as the administrative director in the time that I was there. I also have worked as a children's grief facilitator, a home visiting social worker for pregnant and parenting women in West Philadelphia, and a domestic violence advocate. My social work degree is from the University of Pennsylvania. I'm eternally grateful to the city of Philadelphia for the training I've had there, and the city of Camden for really kind of bringing me up in trauma-informed care and member-centric strategies. So really excited to be here with you today. I'm also a mom to 2 little kids, so I'm an expert cushion fort builder and shuttler of kid activity schedules. So important transferable skills there.
Fantastic. Yeah, Carrie Ann, I think you bring incredible experience and perspective into this discussion. I'm going to turn it over to Sheila.
Hey, everybody. Thanks again for having me here. Sheila Yazadeh. I'm the Chief External Operations Officer for Care First Blue Cross Blue Shield Community Health Plan Maryland. I know it's a mouthful. We are the Medicaid plan in the state of Maryland. We are one of 9 managed care organizations there, which is quite a few if you're familiar with the Medicaid states and all of that. So my background, I started in health policy. It is really foundational to how I approach my role here with Care First. And so since 2021, I have been supporting the business with strategy, member experience initiatives, outreach, and really finding ways to actively listen to the market, our FQHCs, our members, and incorporate those elements and the voice of the member in the solutions that we bring to them. So I'm very excited here to be talking about that member-centric space because it really colors everything that we do and what we hope to achieve as a plan when we serve our members.
Fantastic. Thanks for joining us today, Sheila. And now turn it over to Jim, and then we'll round out introductions with Sebastian, our sponsor for today's session.
Great. Thank you. Greetings. I'm Jim Hickman with Hickman Strategies. My career trajectory has been focused on putting policy into practice, particularly in the Medicaid space. I've spent 30 years working with plans, providers, and all facets of the ecosystem of care, starting with the implementation of Medi-Cal managed care in California back in the 90s. My focus today is on working with innovators who are really trying to use technology to shorten the distance between people getting their needs met by large systems of care. So thanks for having me on this webinar today.
And I know technology is going to play a central role in technological advancements in today's discussion. So thanks, Jim, for being here. And now I'm going to turn it over to Sebastian, our sponsor again for today's discussion.
Thank you, Jamie. And thanks everybody for joining. My name is Sebastian Sager. I'm the CEO of Scene Health. We spun out of Johns Hopkins in 2014. Previously, the technology was named EMOCA. It was named so by Hopkins researchers who used the platforms, one of the first mobile health platforms ever, to help patients with HIV in rural Uganda, believe it or not. We started off serving public health departments. About 5 years ago, we started working with Sheila's plan, the Care First Medicaid plan. It was previously Riverside Health. Then it was acquired by Care First. That was our first foray into Medicaid. We now serve Medicaid health plans nationally. We're excited also to partner with Carrie Ann's team in community and state at United. And we help people take their medication every day, consistently, correctly. And it's a great way to help people achieve a health outcome. Since medications are really important for the chronic conditions. So excited to be here and talk more about how to support the most vulnerable populations in society today.
Thanks so much, Sebastian, and thank you for your support of today's discussion. We're going to dive right into questions, but before we do, I just wanted to mention that we welcome your engagement in today's panel discussion using the Q&A feature. If you have any questions, we will attend to them as we work through today's presentation. We'll start with a few questions, allow our panelists to weigh in, but we'll start to turn to your questions as we move further into the panel discussion. So let's go ahead and start with Carrie Ann and Sheila. The question for the two of you: what does engagement actually mean for you in your organization, and how do you define engagement with your members? Sheila, if you want to kick us off, that'd be
Sure.
great.
Yeah, so engagement for us is really about a member getting connected to care. I've always told the team we want to get our members early into the care journey as early as possible, because while they may not have a condition now, it doesn't mean that life circumstance won't change later, right? So engagement is getting the access point there, assisting them with taking those actions and decisions that are going to get them to that overall path to wellness. So, we have many partners, and we'll talk about our partnership with Scene. Our providers are key to that. Our own care management teams are key to that. But I've always told the teams, it doesn't have to be us being the face of it. If there's a trusted entity, whether that's a provider or a partner or CVO that we're working with, we play that behind the scene role, right? And getting that person connected to the resources they need and ultimately engaged with their care plan and their path to wellness.
Great. Carrie Ann.
I couldn't agree more with what Sheila already offered. And I think to add, engagement is each interaction, a call, a visit to to a provider, a letter, an email, a conversation. Each engagement, it's an opportunity to build trust with members, caregivers, providers, communities, and really make sure that they have the information they need to make choices and move forward in the way that works best for them. I also think the term engagement can be used as like a unit of measurement or a proxy for trust, for confidence, for stickiness, and appeal, right? Like engagement indicates that we're speaking to someone, a group or a community in a way that draws them in a way that's relatable, interesting, and inspires hope. It shows we're hitting the mark in reaching our members with critical information, support, and services.
And I would say with
Fantastic.
Carrie, like to that point, Carrie Ann, it's the two-way, right? So I think we often, sometimes in the payer world, we're sending out text messages, postcards, and we know that, okay, we at least need all these touches to get someone to action when we know it needs to be a two-way street. So that by, dialogue, I think that we can establish as early as possible is so key to not only getting folks to achieve better health outcomes, but sticking with them throughout their change in life circumstance.
Mm-hmm.
Absolutely. That continued bi-directional exchange is so important to meaningful engagement. And I just have to say, I so appreciate your perspectives, having been on the ground and trying to implement some of these strategies, both as leaders and as individual contributors. I think it's invaluable to today's discussion. So Sebastian, I want to turn to you now and just ask, how does the use of technology, particularly video-based communication, play a role in tailoring engagement approaches based on individual needs and preferences? And then are there specific technological tools or platforms that have proven to be effective?
Well, maybe based on what I just heard from Sheila and Carrie Ann, there was a lot of optimism in how you described what you think engagement means. So for sure, the word holds a lot of promise that it's meaningful, right? That it's not just a text message that maybe was received or not, or the unit of measure for billing, right? So for us, as a digital health concept that helps people take medication, the whole concept is based actually on an in-person process called directly observed therapy. The patient and the provider, could be a nurse, could be a healthcare worker, are in a room together, and the patient takes medication. If that was the end of it, could you imagine like somebody just walks into a room, somebody takes meds and they walk? It's a conversations happen. These are people. So our concept is built on replicating all the most important parts of that conversation using video, not just live video actually, but video recordings. So we have to piece together a back and forth of videos. And for us, the measure of whether that is effective engagement is, did the patient take their medication? Did they tell us how they're feeling? Do they tell us why they can't take medication for whatever reason? So the standard is the in-person standard for us of engagement, meaning, do you have a meaningful back and forth with that patient? As far as what technology is amazing, there's no doubt about it. So it can do a lot of things. I do think our technology is great, as you can imagine, but it doesn't compare to our care team. These people really care, really, really, really care. And driving that human touch through the technology, that's what technology is about. It's about amplifying, doing something that a person would do, but they couldn't possibly have the opportunity to do it without technology, right? So you couldn't reach somebody in Texas if you're in Maryland without technology. Anyway, I'll stop talking now, but it's really meant to amplify personal communications, patient to healthcare system.
Yeah, it's really an opportunity to create greater access to care. And I love the fact, Sebastian, that you use that face-to-face interaction as sort of the baseline as you structure your technological solution. So Jim, just curious to know from you, what are some key considerations that organizations should keep in mind when aiming to tailor engagement to the unique needs of individuals with complex conditions?
Yeah, no, I think we've covered a lot of the themes here, but let me add a few more. One is there's just the table stakes of communication. Are you hearing from a messenger who looks like you, speaks like you, has your cultural context, right? So sometimes technology has a difficulty transferring that sort of contextual relationship, but it can be done, and there's novel approaches not including the asynchronous approach that Sebastian just described, to where you can do that, right? So language, culture, and context is the key to building trust. All of these engagements from a health plan perspective start with a very linear process called an algorithm. Yet humans are nonlinear, and our engagement and trust building is nonlinear. And I'd say the third thing I think about a lot when I work in community, including implementing Medicaid waivers right now, is who are the holders of that trust? We spend more time as people than we do as health plan members, right? If you use the 80-20 rule of social determinants of health. So who around the individual you're trying to engage with has trust that you can activate, right? So a lot of what I do and think about is how do we use technology not only to amplify the message that the health plan is trying to convey, but also who is the right trusted messenger to carry that message to those individuals or communities. So that's sort of some things I think about a lot in this process.
And that is a perfect lead in, Jim, to a question that just came up in the chat. And I'm going to open it up to the group. But the question is from one of our audience members: how do you leverage peers or community to drive accountability as you seek to engage members?
That's such a great question. I love that question. I can tell you, I mean, taking it from how we work with our providers and like just for example with our FQHCs, there is the standards and the quality and the HEDIS measures that we're constantly working to achieve with those partners, right? And that inherent in that there is accountability and sort of when we meet with them on a weekly basis and we're sharing the gap in care information and we're hearing back from them, and we're not the only payer that looks at how do we build incentives for providers, how do we build capacity for those providers to be able to help us meet those measures. And then there's the accountability of us as a plan, right? We have these standards that we need to meet, and we work with, as Jim was saying, the trusted face. It doesn't have to be us. And sometimes I say it shouldn't be us, right? Because I sometimes don't want to pick up the phone. After you to pick up the phone from a payer, even if you sometimes don't recognize the number, and a lot of our members are hard to reach. They don't trust the system because the system has failed them over and over again, right? So we need to be more creative and help close that continuum and look at ourselves as part of a system rather than just the payer driving to these measures. And I know we'll get into a couple of more, learnings that we've had as a plan, but that's a perspective, right? I think holding ourselves accountable to the measure, to our members and what they're saying, as well as working to establish some standards and sort of bi-directional agreements with our partners and providers as well.
And Jamie, if I can just add one small observation from the $12 billion plus waiver we're implementing in California right now called CalAIM, there's a real distinction between network adequacy and network equity, right? And that's what we're talking about here. You can have a very adequate network, but is it equitable in terms of opening up access and really engaging in a culturally appropriate and meaningful way?
I feel like too, this was something we talked a little bit about even just in advance of the webinar, was broadening our definition of what member-centric means, or person-centric, right? Is it also community-centric, demographic? Like who are you really working with, and is their voice coming through the intervention, the message, the effort? And so same, as Sheila referenced, hopefully we'll get into some of this, but at United we have a program called Catalyst, and that's the first step. If the community that we're working with didn't identify the problem or opportunity, then we're not going to tell them, that what the problem is or what their priorities are. So it has to be collective and collaborative. And I think when you take it even a few levels higher and you think about communities, like Sheila was describing, the opportunity there to have more relatability, more trust, and more kind of power behind the effort that you're putting in, that kind of makes it unstoppable, because community-driven, community-led, right, is really where this needs to be. And so to the extent that we can serve as a catalyst, and literally that's the name of our programming, that's huge. That's a huge opportunity and a privilege too for us.
Yeah, just so important to engage individuals with lived experience in particular. I love that. I love that perspective in the conversation. And we all know it's not only important, ultimately, your work won't be successful without that perspective, right? So yeah, really appreciate the comments from our panelists. Sheila, I'm going to turn to you with our next question. How does medication adherence play a role in controlling costs for members with complex conditions? And are there specific strategies based on your experience that address the unique challenges faced by members with multiple chronic conditions?
Yeah, well, no surprise. We all know that medication adherence is associated with reductions in utilization for patients and members. I mean, there's plenty of research out there that tells us that. And, you know, when we see a member that is more adherent, we can expect a decrease in inpatient hospital stays and ED visits, et cetera. I will say with our plan this year, we have piloted, I would say, a very high touch wraparound approach to some of our high risk, high cost members, especially on the dual special needs plan side. This is our most complex member population, and we're leveraging our resources. So we've got a tag team of a community health worker, case management, and really hyper focused on giving them the tools and menu to really select what that member needs and handhold them through that process. One of the things, as I was thinking about preparing for this discussion, that we haven't really talked about, and something that will come to no surprise to the panelists and folks on the call, is the barrier of health literacy, not in the sense of what is a claim, but how do I even adhere to my plan, right? And we're not discussing the cognitive load that comes with that and placing that on a member or patient, and then expecting them to not only manage through that, and most of these members have multiple chronic conditions. There's not just diabetes, right? They're going through the emotional pain of that. They are going through the physical pain and experience of that. And now we're asking them to, oh, by the way, you need to memorize all these things that you need to do during the course of the day to get to a path of sustainability. So I think as a result of that, when we are working with partners like SEEN or building those relationships, as Carrie Ann said, it's more so to help alleviate some of that emotional and cognitive load that comes with these diagnoses, right? And giving that person a space to not just talk about what they're taking, but as Sebastian and I were discussing yesterday, talk about their day, which builds that relationship and gets that person connected so that they can get to a place where they can understand what they need to do to get better. I think it's so important that we bring this into the discussion of what we're asking of our members and the things that they're going through in order to achieve wellness, right? Beyond adherence.
So true. And I love the fact that you all have developed this process where you're really tailoring your engagement strategy to the needs of individual members. So important, given the challenges associated with sort of managing their ongoing healthcare needs. So Sebastian, can you talk a little bit from SEEN's perspective about measurable outcomes or improvement in member health and total cost control that have been observed as a result of really prioritizing and enhancing medication adherence among members, in particular members with more complex needs?
Sure. I do want to mention Sheila's comment on the concept of cognitive load. This is serious. This is really serious when you think about, and I will answer your question though, Jamie, for sure. But fact is, when somebody gets discharged, they have a bunch of new prescriptions. They're trying to leave. At the discharge summary might be maybe very hurriedly given to them. They may have other medications at home. The load on the patient to really understand what they're supposed to do next is in many, and given the fact that the amount of time they actually have with providers is ever shortening, that load is placed on the patient in the outpatient setting at their home where they don't have that kind of support. So there is just a true need and a massive gap for helping people out in between these visits in, provider offices or facilities. I like Sheila, the cognitive load piece of that, which is actually at some point, it's not even that you can't remember, it's just you can't even take it in. It's just too much.
You can't even process.
You can't process.
Yeah,
it.
and
Right.
I mean, even now, like after pandemic, right? I mean, I'll speak for myself and like my family, that as I've seen go through different diagnoses and having to process that emotionally, with behavioral health being such a large topic, I think it needs to be part of our understanding of, it's a tall order, right? But how can we further address that?
Right. And no surprise then that when somebody is not understanding this and not able to take these medications, which are, in trials, we know that they work, they're life-saving for hypertension, diabetes, using an inhaler correctly, using the right inhaler, all these things, you can imagine that the outcomes are not surprising that somebody ends up back in the hospital. So in terms of outcomes, we kind of look at them in two ways. We look at them first in terms of a health outcome, and just as important as the health outcome for a health plan like United or Care First is the associated reduction in cost, right? So a health outcome, adherence is a great endpoint too. It's a great outcome, but really the health outcome would be, what's the A1C level, right? What is their blood pressure? Can they use an asthma inhaler correctly and consistently? And it's pretty, if you look at the literature, it's pretty clear. Of course, it varies by health plan, and what is a health plan paying for these claims? But the fact of the matter is, the difference between an uncontrolled member with a chronic condition and a controlled member, it's around about $5,000 to $7,000 a year annually in Medicaid, right? So adherence. And of course, it's not just adherence, because you're talking to somebody. So you find out barriers that they are experiencing. With Care First and also with United, we've worked out these linkage protocols to get, if we discover something, to get them to the right program, because we can't do everything. But it's amazing what you can achieve when you partner well and when you actually solve a real problem rather than just quote unquote like engage, right? Other outcomes are on the other side, linkage to care type of outcomes. So people can't take meds if they don't have three really important things: provider to prescribe them, labs so that the provider knows what the patient's condition is, and then finally, of course, they have to have medications, right? So the great thing about linkage to care is that CMS defined in those HEDIS and STAR metrics a really nice roadmap, with, for example, the AAP measure, or for diabetes, the comprehensive diabetes care. Those measures really track to what somebody needs to be adherent to medications. Those outcomes just published from Care First are somewhere around 40% increase to what you would typically see without intervention.
Wow, that's really incredible. Thank you for that, Sebastian. We do have another audience member question, which I think is probably best suited to Carrie Ann and Sheila, but I'll just pose it and open it up again. How similar are the care plans for patients with chronic conditions? The terms we use make cases feel very unique and one-off, but is that really true?
I was thinking about this as we were coming in, and really about the intersection of technology and, person first, member-centric, right? Like the terminology that we're using. I think person-centered care, trauma-informed care gives us a framework. It gives us principles, it gives us values, culture, right, to approach. But at the end of the day, what kind of artifacts, what kind of tools, what kind of materials come from our programs, as deliverables on an engagement, a true engagement with someone, and how does that kind of become unique? And I actually think technology is one of the best tools we have, honestly, in our toolkit to keep up with and keep consistent with values, aligned to person-centered care and trauma-informed care, but do it in a way that's standard, predictable, easy on the workforce, right? Making the bad hard and the good easy. Technology, I think, is one of the things that through United, that, in our documentation systems and platforms, we've actually translated person-centered trauma-informed care principles into our care plans so that things like readiness for change are accounted for, so that within a category of an individual, of a condition an individual might be, living with, there are a number of options depending on where the member is to select as the right intervention at the right time based on, the situation the member is in and their readiness for change. So for example, we'll stick with diabetes just because it's sort of, the most common to kind of talk about. But if the goal is to improve diabetes management, but to Sebastian's point, they don't even have a provider yet. They've never had, they haven't had an A1C lab value drawn in years. You need to tailor that. Our system allows for that. So far, our systems have to also hold up the values and principles of person-centered care so that it always feels like the same approach, but is easily tailored to a member's unique profile, unique, set of needs, the unique clinical, interventions for a condition. But whether we're talking about, asthma or diabetes, you want it to feel like, oh, I'm getting the same kind of care, but it is, it is unique based on where that member is, what tools they have in their toolbox, what barriers, gaps, might be experienced through SDOH or other factors, and let that be documented. And so I'm really proud of that work that we've done here. And I know that's been a transformation in technology in general to not just make documentation easier, but to make documentation actually person-centered.
And I'd love to do a callback to some work Jamie, Carrie Ann and I did a while ago. It's centered in Camden. In addition, I'm an advisor to the Camden Coalition's National Center for Complex Health and Social Needs. And out of that has come a complex care certificate that was just launched where, you got to build principles. I called it build analog before you go digital, right? So there's a lot of effort to really make clear what are the standards and principles that must guide all our interactions, whether they be in real life or on a digital platform. And so I just want to thank Carrie Ann for showing us how we make that transition there.
One thing, not to repeat what Carrie Ann said, because I think that's spot on. And then my head kind of starts going into what is the role of AI and all of this down later. It's a webinar for another day. But one of the things that often comes up is, we do these care plans and we send them to our providers and we send them to our members. But I would have to say, again, message sent does not mean message received. And so one of the things that, and I haven't found a great solution to this yet, or, and I think we're all trying to collectively work at, is with providers that are already receiving so much information, that already have such limited time, and we're creating these care plans that do have unique elements to address social barriers. How do we bridge that gap and make that connection so that it is more coordinated? I see a question coming up here on that collaboration. I mean, that high touch collaboration that I'm talking about, it is a lot more effort. Right now, it's focused on a very specific cohort of folks to help that are contributing to the highest cost within our plan, right? But when we're talking about thousands or millions of members, that's where the segmentation, the triaging comes in to be able to address things and start to get to ROI. So, I put that out there not because I have an answer, but something to think about, because as we plans, payers create these care plans, they're part of some of our regulatory model of care requirements. But how are the providers using them? And do we need to reconsider how that interaction works too, to make sure that we're getting our members the best care?
I also like one theme that I feel like always strikes me is that there's population health, where you may establish best practices that you want to apply, and then you may segment your population in certain ways. And there's nothing wrong. It's actually a great strategy. There are many strategies here, but as soon as you reach the individual member, if it wasn't a little bit different every time, then you wouldn't need people to manage this, right? You could use robots or something. But the fact is that at the individual level, you don't know the specific problem, and you'll discover it when you start talking to somebody. And providers struggle with this all the time because they encounter somebody whose A1C is out of control, but now they discover there's a substance use disorder, right? Or they want to discharge them, but they have nowhere to go, right? So there are so many variables that you'll have to manage once they're in front of you. And that's a big tension, because you can't just throw a program out into the wild and expect an outcome. Like a great example that we always use here is, let's say somebody's 100% adherent to their diabetes medication and their A1C does not go down, right? So we feel many times we would feel, oh, that's a failure. We didn't get to the outcome, but the real outcome would be change the medication, right? We need a different medication here because this one's clearly not working. Massive win for the provider if they find out and are able to take that information in. Then you can actually really solve this problem. So there's always, there's strategies, and then there's what you have to do when you actually meet the person who you have to try to help.
Yeah, really nice sort of common theme among the panelists, right? In terms of having that sort of baseline standard of care, but then really, really tailoring ultimately your solution to the needs of the individual. We're going to shift focus a little bit. And I'm going to pose a question to Jim. Jim, I know that you are steeped in the use of data to derive decision-making, which I love, and every Medicaid director in the country loves and appreciates. So if you could talk to us a little bit of the role of data analytics, predictive modeling, and other like tools in identifying and serving members with complex conditions, that would be fantastic.
Yeah, no, I feel for my colleagues in the managed care space, because you have a large line of people outside your doors telling you that AI can slice and dice bread in any configuration you like. And honestly, this is going to sound funny for someone who lives in the Bay Area and drinks and breathes and technology every day. A lot of what you're being offered is over-engineered for your needs, right? And so to me, at the end of the day, AI, predictive modeling, all these buzzwords do something very simple. They generate a list, right? At the end of the day, the output is a list. So it comes back to the theme of this panel. How do you activate data to meaningfully engage your members? And, I'm real simple. I start with one thing, right? One case finding exercise. This is what I do a lot with my clients. And I'll use an example. Let's do falls, right? ICD-10 Z9 1.81, right? Fall, history of falling. That's a small thing, but honestly, if you looked at the history of falls in a neighborhood, and then talk to your area agency on aging, or you talk to your fire department, you'd suddenly have a really interesting picture of something going on in your community. That would actually, as Sebastian said earlier, really open up some other avenues for engagement, right? So I think we get, the trick here is to take data and make it actionable and meaningful to the individual you're trying to help. And then the last piece is, who's the last mile in that engagement and conversation? There's a question posed about CHWs and their role here. What we're seeing in California, there's a lot of digital outbound engagement. All that work that these lists are being generated by AI, coming both from the state and health plans, are actually ending at the endpoint with an individual contacting an individual, right? So your list is only as good as the data that you start with. That list gets better when the human confirms sort of both the data and the needs driving that list. That would be my takeaway.
Great. Thanks so much, Jim. I'm going to actually turn to another audience question, and Sebastian, specifically to you. It says that from the audience member, the most effective resource I've seen for family members is an in-home visit sent by the MCO or the health plan. Even when the family member thought they were doing great and didn't have issues, in reviewing their medication, they saw that they were given medication for the wrong person from the pharmacy. And since the medication looked the same, it did not draw attention. So that from the perspective of the audience member, that in-home visit is really important. Just curious to know your thoughts on that, given the work that you do at SCENE.
Yeah, it's no surprise that if an MCO could send community health workers into people's homes, you'd resolve a lot of problems. And of course, it's quite expensive, but programs, in-home programs are really, really effective because you discover all the things that you can't figure out on the phone call. Interestingly, the model that we use, directly observed therapy, was an in-person requirement for all public health departments in the country for tuberculosis until March, when the CDC wrote into their standard of care that you could use asynchronous video visits like we do, right? So the in-home visit is amazing. It's like, but the question is, how do you scale that? Now, to that question that I'm reading now, it's actually awesome. Mistakes happen in person too, right? So can you imagine if mistakes can happen in person, what happens on the phone? All the miscommunications that can happen. So having as much contact as you can, and time is a very precious thing, right? Clearly our bricks and mortar and providers don't have it. So hopefully in between, we can eventually find the time for members. But we've seen all sorts of things like this, like somebody's injecting insulin, but they haven't taken the cap off. And so, you know, obviously medication's going nowhere, or they're taking their inhaler every day, but they've swapped the controller and the rescue and didn't realize that. So mistakes happen. Medications are not so easy. And especially if somebody has a cognitive issue or they have 10 different, 15 different medications, of course they get confused. Mistakes happen and they're really expensive. So to that specific comment, I'd say a medication reconciliation, a med review. And I don't mean for the purposes of checking the box on CMS's star measures or something, but a real pharmacist medication review with the patient is critical to make sure that complex conditions that the patient understands what they're supposed to be doing to get better.
And I would agree with the participant who put that in the in-home assessment. I mean, we're seeing that, right? Like the rise in in-home needs, and it's not funny, but it's ironic, right? Because it feels like we're getting back to basics when you used to see the doctors come home to visit, and to the point that Jim was making earlier, you can have all the data to give you the direction, but it's still that human touch and that interaction that's going to tell you and validate and get to the last mile for that particular member patient. So yes, I mean, as a plan, we are working with vendors to do in-home assessments and have that and are working with folks that are feet on the street to be able to get into contact with the folks that they can't reach, right? So we're working with all of our vendors and making every touch point as intentional and meaningful to be able to let them know that this is available to them.
And if I can just add one piece of policy to this, we've seen both Medicare and certainly Medicaid, increasingly reimbursing CHWs in the process, right? So, there's also a workforce component to this conversation and how we tech enable and connect that workforce as well. So I'm an optimist that we're identifying problems that policy will eventually solve, and innovators like Sebastian and team will make a good business.
Yeah, I mean, there aren't more doctors and nurses coming, right? So in fact, it's quite the opposite. And pharmacists have their own issues right now of burnout in the retail setting. So the community health worker, there was a question before about a peer. This is pretty important to find out how we amplify and expand their capacity.
And Sebastian, do you want to talk a little bit more about how your tech solution works on the ground with members, and in particular in serving members with more complex needs? What does it look like in reality?
Sure. And in general, we serve members almost exclusively with complex needs, and always have since we're coming out of public health. But very, very simple way to explain is that patients are opening up our app, video recording themselves, telling us how they feel, and taking their medication. And on the other end, at another time, so shortly thereafter, our virtual care team reviews that and sends a video right back to the patient, a personal video. And to the AI points, Sheila, let's go for it. If you want to. I will say at some point, every time I tell people how we do it, they're like, oh, could a virtual AI, avatar send the message? Or we actually experimented with pre-recording our care team messages, especially the ones of encouragement, what a total flop. You need like professional actors and actresses to pull that one off. Other the patient totally knows that that's a recording, and it's a fail, and they just stop logging in. It has worked with providers where we tell the patient, hey, here's something funny from your provider, and it's like known that it was pre-recorded. But you've got to be careful.
I think until AI can make an emotional connection with someone,
right.
We're probably still in the business of human touch, right?
Yeah, I would definitely say so. I think human touch is amazing in general. Like, it's a great thing. It makes people feel good. And I know people are very lonely and isolated, et cetera, but I'm not sure computers are the solution to that. Open to other opinions, of course.
No, I think at this point in the evolution of AI, Sheila's right on the mark. We're not there yet. So speaking of sort of a question that I want to turn to Sheila and Carrie Ann on, can you share some examples? And Sebastian shared an example earlier, but I want to hear from you as health plan leaders, some examples of where these types of proactive member-centric strategies and interventions have worked to reduce or I would say contain the cost associated with serving members with more complex needs.
Yeah, definitely. Okay, thanks, Sheila. I mentioned our United Healthcare Catalyst program earlier, and we have those live in a number of markets, but recently launched in Maui, and with a focus on diabetes, which was identified by the community, with interventions identified and co-signed by community leaders and partners and constituents. And what that program does is kind of serves as the connective tissue, right, between community and sort of more formal interventions, maybe that need funding or need other kinds of investment to really kind of get off the ground, launched, promoted, right, and kind of supporting communities in engaging their own, engaging from within. And so that program in Maui is focused on diabetes. We're already seeing members who are kind of identified as the measure, for measuring whether or not there's an improvement. We're already seeing significant improvements in hemoglobin A1C measures and in blood pressure rates or lab values. So what we also know is that improvements in those very kind of technical measurements translate to utilization, translate to risk, translate to financial burden, but also community burden, right, and sort of distress as well. So I'm always ecstatic to talk about that, because it's again that broadened definition of not just a single member, but really kind of looking at a community as an entity, and focusing on investing in ways that get ahead of perhaps some of the most complex and comorbid conditions. That program did a lot with locally farmed food, right? Food is medicine, medically tailored meals, ensuring that social determinants were met, and really kind of doing that quietly in the background while being a significant partner to that community. Having it be community led really increased the engagement with individuals. You have established trust. We were just there to bolster it and really kind of help accelerate it. So I think that ultimately the goal there is to also have created enough connection and again, I'll use the word stickiness again, to ensure that the intervention is sustainable, right? You don't suddenly you swoop in, make a deposit of something, and then vacate. That doesn't work. We know that doesn't work. So part of the program too is about creating a sustainability plan so that those resources, services, interventions are permanent. They are there as long as the community wants and needs them, whether or not we or other partners are at the table, because we kind of that's the goal, is to be able to then say, you've got this, you've totally got this. So that's really, really exciting.
Yeah, and to kind of add to that, when we talk about cost of care, which is a hot topic for everyone, Sebastian mentioned some of the results that we've seen with Scene Health, and one of the things that I had asked him yesterday, and hopefully can work on with our quality team as well is, these folks are coming in, they're going into the program, and ideally, once they're adherent and understand how to take that medication, they don't return, right? But we know that life doesn't work that way. Your circumstance is going to change if you are with us for an extended period of time, and then hopefully you're getting your preventative checkup so that we can get that and check that to see ahead of time. But life happens. So we are in the midst of wanting to understand, okay, what is the longitudinal study on this, right? And, I'm sure I'm not the only payer out there that we work with a lot of different vendors, and we need to begin to stitch all of that together and understand ROI end to end, right? So if I'm bringing Scene Health upon diagnosis of someone, or if their diagnosis has changed, how am I then doing the handoffs to all these other vendors that I'm working with to ensure that the continuum is covered? And I know that some payers are a little bit farther along than others, but really what we're talking about is that orchestration around the member so that we are doing those warm handoffs, we are taking them through the journey, and we're really maximizing every vendor and touch point we have to determine that ROI, because it's not just going to be one episode. And I think we're so used to getting into that system of measuring based off of acute episodic care, when really it's the lifetime of the member that we need to understand, and the value that we're driving with working with these different vendors, partners, and interventions. So to be seen, right? No pun intended, Sebastian.
Yeah, if I can just add, I feel for health plans and the point solution exhaustion they're all experiencing, right? And so a lot of the work that we're starting to see happen organically in California is you're starting to see meaningful partnerships amongst vendors to offer a simplified tech stack with a lot of partner integration. So they show up and say, really, we can do 80% of what you need is if you work with these 3 vendors, you're going to get 80% of the way there. And I think that is a foreshadow of greater things to come, because it's just too hard as a plan to manage 50 vendors. Unless you've sliced your population, your population is so big that you can slice it that way. It's very hard to do.
But it's almost mirroring, right? Like the silos that we've created in the healthcare system as a whole. The reason we have this is because we have all these needs. So if we keep talking, around whole person health and whole health. We are not operating as a whole system to begin with. So I agree completely. And I've started to see that too, versus this one-to-many relationship, one-to-one, and then they, manage the continuum, which ideally then gets us into, this is where we should begin in the first place. So, I think it'll be a evolution towards that. And hopefully there's things that we can do in partnership with, Scene and other the vendors to help with those handoffs. And we're doing it now. We're getting some of our vendors that are feet on the street trained up on all of these other services so that they have a direct line to refer, call, and hand off. And now it's up to us to really look at that end to end for that whole person and whole journey.
Yeah, and Jim, there are a few people like you, right, who, because this is early days of applying technologies and technology-enabled services to fix problems. So if you look at, studies, literature, these are over decades for certain interventions. So to the extent that an intervention is brand new and there's no basis in literature, we're talking years, right? And to the extent that it's a digitized version of an existing standard of care, okay, well, you can lean on that. You still have to prove out, as Sheila was saying, you're still going to have to prove out the effect on total cost of care. And I totally agree, though, that it is partnership, because these things are ever evolving and improving, and you can't just grab a solution and stick it in and expect that it doesn't change. These things have to improve over time. The reach rate, the enrollment rate, the adherence rate, these things are capable of improving with more technology or more human touch or different workflow, plugging in other vendors like you're saying. So we're very, very early, and it is many, many, many cycles of rapid adaptation and total mastery of data, really.
Yep. And again, it's back to analog before you go digital, right? Because everything underlying all this conversation is proven workflows that are based on proven, methodologies of intervention, right? And so if those are underpinning it, then the technology layer gets a lot easier. It's when you do the reverse that we see the proliferation of, point solutions without a meaning.
So true. And it's really clear, I think, to me from today's discussion that Sebastian, your team has partnered really closely and on an ongoing basis as things have evolved with your health plan, the health plans that you work with. And that makes a huge difference. And just the willingness to acknowledge that things are going to change and you're going to need to evolve is critical. And not everyone does that, frankly. And so just really, really nice to see that iterative approach sort of baked into how you do business. So I'm going to turn to Carrie Ann for a moment, and then we'll probably have to wrap up. We're only 4 minutes from the top of the hour. But Carrie Ann, I know you've worked in healthcare practices, in people's homes, obviously in managed care. Often person-centered care, quote unquote, feels like the responsibility of frontline workers, but we all know that it extends well beyond those that are hands-on with the member. So what can you recommend for our audience members who may be frontline staff or C-suite executives that bridges what may feel like a disconnect in defining what works and what success looks like?
I feel like this has been my my life's work, which is bringing what can be considered, or it's called often clinical, practice really into kind of organizational design development. The reality is person-centered care, trauma-informed care, they're both about building trust, showing empathy, treating people with dignity, meeting them where they are. It means we're operating with the understanding that individuals, families, and communities, they're experts in their care, right? And that's something that both frontline staff, C-suite executives, right, Medicaid leaders can all appreciate and understand, no matter the seat they're sitting in at the table. Really, the thing, I think, the concept from person-centered care and trauma-informed care that connects, that is sort of critical, is moving from a view on the people we serve and just kind of people in general, from what's wrong with you to what happened to you, and I would argue the addition of who are you. In the kickoff of this webinar, Jamie, you shared, right, 6 in 10 adults live with at least one chronic condition. Let me add to that sort of statistical, knowledge set here. It's estimated that 70% of adults in the U.S. have experienced some type of traumatic event at least once in their life. That's more than 200 million people. Trauma is prevalent across our society, regardless of income status, race, ethnicity, geography. We know exposure to childhood experiences is the most significant determinant of health and social outcomes. And so, the reality is we sit in spaces with people who've experienced trauma. We sit in those spaces with our members. We're sitting in those spaces with our colleagues. We're sitting in them with our leaders. Our leaders are sitting in them with their direct reports. This is reality. This is what, connects the responsibility to everyone kind of in an organization that wants to be seen as and operating as trauma-informed and person-centered. We're really looking to these concepts and principles that we've kind of talked about that have, been referenced today, in a way that says we operate in a trauma-informed, person-centered environment, and that is not just for the benefit of the members we are privileged to serve, but that we're taking care of our employees, our staff, and ourselves. In that way, right? It starts certainly with a demonstration, a leadership shadow, a culture, an organizational culture, and sort of value proposition that it has to be lived every day, because then it's not hard for frontline staff to say, oh no, I'm operating just like my CEO. I'm an ambassador of this culture, of this organization that I know sees people with the utmost dignity and respect for them as the expert in their care journey, and this community and the expert in what they need. And so, really ensuring that things like, that are kind of simple, like language choice. How are we talking about people in general? Are we calling them by their diagnosis, or are we explaining something they're living with and managing and sort of adding a resilience factor to it? I think that's super important, pervasive, and something that easily anyone in a role, a across an organization can get on board with. I know we're at time. I could talk for hours just on that. So I'll leave it there. But really, there are some very basic concepts that executives, leaders, frontline staff, midline management, like the principles kind of run vertically there.
Yeah, I think you really did a wonderful job of kind of summarizing many elements of today's conversation. I think it's been a fantastic discussion. I wish we had more time with you all today, but unfortunately we are at the top of the hour. I just want to thank our panelists. Tremendous discussion and guidance to our audience participants. I also want to thank the audience for joining us and for posing some really wonderful questions to us, which hopefully we were able to address as we went along. But again, thanks to Sebastian and team for hosting. Thanks to MHPA for allowing us this opportunity. We look forward to additional opportunities to talk about these important topics.